Hi, my name is Shaji Kumar. I'm a consultant in hematology at Mayo Clinic in Rochester, Minnesota. The NCCN, or the National Comprehensive Cancer Network guidelines for multiple myeloma, is constantly revised based on updated results from clinical trials, as well as changes in disease definitions and introduction of new tests and diagnostics. The current version of NCCN guidelines continue to add the new therapies that are increasingly available for the treatment of multiple myeloma. Over the years, we have also added separate sections to deal with specific areas in plasma cell disorders that are important to the practitioners. We have expanded particularly on the definitions and the approach to smoldering multiple myeloma. We continue to update the staging and the risk stratification systems for multiple myeloma as well. We know radiation therapy does not play a major role in the treatment of myeloma, but do have definitive role, particularly in the setting of neurological emergencies, as well as for palliative options, particularly symptomatic management of pain due to osseous lesions. In addition to the myeloma aspect, we have introduced sections that deal with the monoclonal gammopathies, particularly monoclonal gammopathy of clinical significance, focusing on monoclonal gammopathy of renal significance and neurological significance. We also added a section on POEMs or polyneuropathy, organomegaly, endocrinopathy, monoclonal protein, and skin changes, POEM syndrome, in order to increase the utility of the guidelines. In terms of the specific changes over time, the importance of the use of imaging techniques, advanced imaging techniques, including the FDG PET and the whole body low-dose CT scan, has been emphasized because this can be important not only for the diagnosis of extramedullary disease, but also for continued follow-up in these patients. The importance of minimal residual disease testing in the management of patients with multiple myeloma has been emphasized, as has been the utility of plasma cell FISH in order to identify the cytogenetic abnormalities at baseline that can significantly affect the management of patients and outcomes. We also included testing like the NT-proBNP that is important to rule out concomitant cardiac amyloidosis in these patients. Now, for the treatment of myeloma itself, the treatment options continue to evolve as new therapies have become available. The primary therapy of myeloma includes the use of autologous stem cell transplant as part of the initial therapy in patients who are eligible to undergo autologous stem cell transplant. In addition, we have also included all the updated response criteria over the years for the management of and understanding the depth of response in patients with multiple myeloma. The primary therapy for patients with newly diagnosed myeloma who are eligible to undergo autologous stem cell transplant includes triplets like carfilzomib, lenalidomide, dexamethasone, as well as quadruplets like daratumumab, lenalidomide, bortezomib, and dexamethasone based on results of some of the recent phase 3 clinical trials. And we outlined the maintenance therapy with one or two drugs based on specific situations such as high-risk multiple myeloma. For non-transplant candidates, the daratumumab, lenalidomide, dexamethasone is one of the preferred regimens, again based on the results of the MAIA study. And for patients who are have relapsed multiple myeloma, the various 3-drug combinations, including the different proteasome inhibitors, immunomodulatory drugs, and anti-CD38 monoclonal antibodies remain the mainstay of therapy. We categorize the guidelines to include treatment amongst patients with bortezomib refractory and those who have lenalidomide refractory disease, and the newer therapies such as the CAR T cells, both ide-cel and cilta-cel, as well as the bispecific antibodies targeting BCMA like the teclistamab have all been included as part of the treatment options in patients with relapse or refractory disease. The supportive care management section has been updated over time and now gives clear guidelines in terms of both venous thromboembolism prophylaxis as well as infectious disease prophylaxis, particularly with respect to the specific settings such as the CAR T cell therapy and the bispecific antibody therapy. In addition, there are various risk factors for the venous thromboembolism, and the risk scoring systems have been included as part of the guidelines as well. And then the identification, particularly the diagnostic approach to patients with monoclonal gammopathy of clinical significance, and how we can identify the underlying clonal abnormality and then treat it based on the additional guidelines have been outlined as well. So overall, this continues to be a valuable resource for providers taking care of patients with multiple myeloma, and the patient versions obviously important for patient education as well.